antigen, and if there no test is negative, no antibiotics are needed. If the test is positive, antibiotics will be needed. If the score is 2, again do the rapid antigen test. Score 3 again, because chance is 30%. So do a rapid antigen test, and if the test is positive, treat with antibiotics. And if the score is more than 4, we can give empirical antibiotics without doing any testing also. So diagnosis, it's a 2-step process. Clinical evaluation, clinical scoring. So उसके लिए हमें क्या क्या देखना पड़ेगा कि बच्चे का फीवर कितना है, lymph nodes हैं या नहीं है, खांसी है या नहीं है, और गला एग्जामिन करेंगे तो गले में क्या मिलेगा, एक्सुडेट्स या रेडनेस मिलेगी, बहुत रेडेड स्पॉट्स मिलेंगे, पेटिकल स्पॉट्स मिलेंगे. So the group A beta hemolytic streptococcus may be ruled out by rapid antigen test, culture, or both. So if the score is less than 3, do a rapid antigen test, and if the score is only 0, then one can wait and watch. Maybe re-examine after 48 hours. So pharyngitis itself is easily recognized clinically, however its cause is known. So differentiating the viral and bacterial tonsil pharyngitis is important to prevent inappropriate antibiotic use. जो criteria बताए थे, absence of cough, lymph nodes, temperature more than 38 degrees, tonsillar exudates, age between 3 to 14 years. These are most common causes of bacterial. So a quick comparison of group A beta hemolytic versus viral typical features are: onset is sudden in cases of bacterial, and in viral it's gradual, and there may be some pain in the throat in both. Fever normally in viral will be around 98 to 100, and in bacterial will be more than 100. Tonsils, there will be slight redness, but in cases of bacterial there will be hypertrophy and purulent exudates. And normally in bacterial there will be headache, nausea, vomiting, and abdominal pain. In cases of viral, the headache, diarrhea, rhinorrhea, conjunctivitis, and cough may be present. And adenopathy lymph nodes are rarely seen in viral, but in interior cervical lymph nodes are inflamed and painful in cases of bacterial. And age is 5 to 15 years. In viral, it's mainly in adults or children less than 5 years of age. And the bacterial infections are seen mainly in the winter, and the viral infections are seen throughout. So the rapid identification and treatment of patients with group A streptococcal pharyngitis. Clinical features alone do not reliably distinguish between the group A streptococcus and viral pharyngitis, except their obvious vital signs. Positive rapid antigen tests do not necessitate backup culture because they are highly specific, and treat with antibiotics only patients with positive rapid antigen test, and negative rapid antigen test should be backed up by a throat culture. If test negative आ गया, then do a throat culture. The report will come in 2 to 3 days, and then treat accordingly. So treat with antibiotics only patients with positive throat culture. So the rapid antigen test enable early treatment with symptom improvement, reduces risk of disease spread and associated morbidity. Rapid antigen tests have been benefits of ease of use, rapid turnaround time. 10 minutes में report आ जाएगी आपके पास, and high specificity. You can do it the point of care also. Like wherever you are examining, just take a swab, apply it there, and report will be available to you within 10 minutes. But have relatively low insensitivity. The use of rapid antigen test plus confirmatory culture testing may help in limiting inappropriate use of antibiotics and prevent the development of bacterial resistance. The need of appropriate antibiotic prescribing is to improve the clinical signs and symptoms, prevent acute rheumatic fever. Acute rheumatic fever कब होता है? पहले streptococcal throat infection होगा, then the child can develop rheumatic. Prevent suppurative complications, prevent death, rapid reduction in contagiousness, and reduce the transmission of infection, and rapid return to the usual activities, and prevent the development. Why to use? We need to prevent the inappropriate use also, to help prevent the development of antimicrobial resistance, treatment failure, minimize potential adverse effects, and it has economic cost also, because all the drugs will be costly. So what are the guidelines? So the guidelines, we can use either penicillin B, which is a preferred drug according to ICMR, and the infection disease study group of NICA, and benzathine penicillin, but that we mainly use for the rheumatic fever patients, where we can give monthly injections of benzathine penicillin because it needs to be given IM. Moxicillin is 50 milligram, maximum dose is 500 milligram, or 25 milligram BID for 10 days. And in cases of penicillin allergy, we can use clindamycin or azithromycin. Clindamycin doses of 7 milligram per kg 3 times a day. Maximum dose is 3 milligram. And azithromycin is 12 milligram per kg per day. Maximum is 500 for 5 days. Azithromycin can also be used in 7.5 milligram per kg per dose in 2 divided doses for 10 days. Ceflexin can be used in 20 milligram per kg BID, and cefotoxil again 30 milligram per kg OD once a day. Maximum doses at 1000 milligrams. So adjunctive medications like acetaminophen or non-steroidal agents or corticosteroids are not recommended. Only in cases of fever or pain we can use paracetamol. So what are the complications? There can be separated complications such as peritonsillar or parapharyngeal abscess, or there will be swelling beneath the tonsils, or non-separative complications like scarlet fever or acute rheumatic fever. Scarlet fever, again, there is a body rash. It's called swimsuit distribution. Body polypen nazar aata. Because of our dark skin, we normally do not notice it. But if you look carefully, one can notice, and there may be some desquamation. थोड़े दिन में ना हाथों से skin भी निकलनी शुरू हो जाती है. So peritonsillar and parapharyngeal or retropharyngeal abscess can be there, and even post-streptococcal glomerulonephritis can develop. So untreated group-based streptococcus may lead to suppurative complications and sometimes to rheumatic fever or glomerulonephritis. The priority over the past 15 years have been the prevention of group-based streptococcal complications such as local suppurations, invasive infections, and acute rheumatic fever. Because acute rheumatic fever will affect the heart, and it is going to be a lifelong condition. So one need to prevent episodes of acute rheumatic fever. So these complications are rare in industrialized countries. The prevention of these complications has used the large-scale prescription of antibiotics. So the evidence-based approach, amoxicillin chlorogenic acid has proven efficacy and is recommended by a major guidelines in bacterial Tonsillopharyngitis. It's strongly, IDSA strongly recommends the amoxicillin chlorogenic acid in chronic carriers of group A streptococcus and recurrent Tonsillopharyngitis, because it can lead to a bacterial eradication of around 89%. It will clear out the bacteria. And the clinical response is as high as 99%. So most of the cases are going to be improving. A multicentric randomized single-blind study comparing efficacy and efficacy of cefaclor and comoxicillin in 10-day regimen of ambulatory patients with acute Tonsillopharyngitis. 200 patients were studied. Out of these, 192 patients completed a post-therapy visit. Both treatment regimens were highly effective and there was no significant differences between the treatment groups. There were no statistical difference between the treatment groups and no stimulus found to be resistant to both them. But if we compare it to azithromycin, only 78% are susceptible to azithromycin, the group-based streptococcus, whereas